Assalamu alaikum. I'm lecturer Dr Hasanain Kahtan. Today the title of my lecture is Surgery for Geriatric Patients. Introduction. Due to significant advances in medicine and surgery, the percentage of people living to older ages is increasing. The portion of the population older than age 65 years in the US is estimated to increase in size from 12.4% to approximately 20.7% by the year 2050. As this section of the population increases, it's important prior to undergoing surgery to understand the factors that influence life expectancy, the actual life expectancy of the individual patient based on their overall health and the quality of life post-operatively. In the last 20 years, the number of patients in the US over the age of 65 who had surgery of the maxillofacial and pharyngeal area is increased. This increase in the amount of operations is not entirely due to the increase in the number of older patients. It is also a shift in the medical and dental professions to offer more invasive treatments to the elderly. With the advancement of anesthetic techniques and monitoring, the chance of encountering an anesthetic complication secondary to the surgery has decreased. Although there is a definite age-related increase in mortality, studies have shown that chronological age has minimal effect on the overall outcome, and that is the coexistence of various disease processes that actually have the most importance in adverse outcomes. Prior to initiating therapy, a thorough history and physical should be obtained. If there is any question as to the accuracy of the medical history, a consultation with the patient's physician should be obtained. If the patient doesn't have a physician, an appropriate referral should be made. The most susceptible populations to local anesthesia overdose are the pediatric and geriatric populations, mostly due to their low body mass. In the elderly, the nerve axon function deteriorates, nerve morphology changes, and the surrounding fatty tissue disappears, leading to an increased sensitivity to the local anesthetics, necessitating smaller doses. Cardiovascular disease comorbidity can also make the geriatric patient susceptible to hypertensive crisis, congestive heart failure, angina, and arrhythmias. For patients with pre-existing cardiac and cardiopulmonary diseases, it has been suggested that the maximum amount of epinephrine that should be administered is 0.4 mg. The approximate amount into 1.7 to 2 milliliter carpals. Although multiple studies have shown an increase in plasma epinephrine levels without concurrent hemodynamic response. Is dependent on the patient's weight, the volume in each carpal, and the percent volume of the anesthetic. A relatively safe amount of anesthetic agent that can be administered to the geriatric patient is approximately 70% of the maximum dose supported by the manufacturer. Note, each local anesthetic agent has a slightly different maximum dose, and the practitioner should know the maximum daily dose for each agent they are administering. Sedation and general anesthesia techniques. Before engaging in sedation and general anesthetic use, a thorough, appropriate history and physical should be taken for the determining coexistence of systemic diseases. In 2002, 2. The American Society of Anesthesiologists published a guide for preoperative preparation of the patient prior to operative and non-operative procedures, where they classify the patients to 5 classes, from the normal healthy patient, class 1, to the most serious condition, moribund patient not expected to survive, which is the class 5. Mostly on 4 important factors: age, number 2, the patient's physiological status and coexisting disease, 3, whether the surgery is elective or urgent, 4, the type of procedure. The most important factor in preventing complications was a preoperative review by the patient's physician. Anesthetic agents. Nitrous oxide. Inhalation, sedation, and analgesia utilizing nitrous oxide is generally considered a safe method for pain and anxiety management in the elderly because of its rapid elimination and minimum effect on the cardiovascular system. It is non-invasive, easily adjustable, and quickly reversible. Nitrous oxide is a colorless, odorless, tasteless, non-flammable, non-irritating inorganic gas. The exact mechanism by which it functions is not known. A preoperative mental evaluation should be done to assess cognitive function because of the commonly occurring episodic dementia. Difficulty due to the difficulty in titration of an effective but safe dose. Polypharmacy in the elderly is very common and can make it difficult to accurately assess the patient's metabolism and their current medical regimes. Complications that occur can result in hypotension, apnea, and unconsciousness resulting from cardiovascular compromise and respiratory depression. The pharmacological agents used most commonly include antihistamines, benzodiazepines, and opioids. Antihistamines are generally a safe medication that can be prescribed. The 2 most common are diphenhydramine and hydroxyzine. Although they do cause some drowsiness, they do not have an anxiolytic effect. The patient will also have hyposalivation that can exacerbate their pre-existing polypharmacy-induced xerostomia. The medically compromised and cognitively challenged. These medications should be given in lower doses for the elderly because of decreased metabolism and delayed clearance of the agents. Shorter acting benzodiazepines like triazolam or lorazepam are a better choices for these reasons. Intravenous sedation. Intravenous sedation is a generally safe and effective procedure for both the healthy and frail elderly. As with any sedation, the patient should not have anything to eat or drink after midnight before surgery. At the consultation appointment, the patient should be counseled to continue their normal medical regime and that it is acceptable to have a small sip of water to swallow their medication. Monitoring is required before, during, and after procedures. Essential monitoring includes pulse oximeter, ECG, blood pressure monitoring, and a continuous recording of vital signs. Kyphosis. When placing the intravenous angiocatheter, particular care must be taken due to the fragility of the skin. Adhesive tape to stabilize the site must be positioned carefully so as not to abrade the skin. Medications that are generally used are benzodiazepines, specifically midazolam. Midazolam is a short-acting water-soluble benzodiazepine which is a safe and effective anxiolytic with the added benefit of retrograde amnesia. Cardiac and pulmonary suppression should be avoided in patients with coexisting cardiovascular disease. Medical management of common surgical comorbidities. Anticoagulant therapy. The uses of oral anticoagulants are very common in the treatment of thromboembolic disorders secondary to cardiovascular insufficiency in the elderly. The anticoagulant effect of these medications must be evaluated prior to surgical procedures. The three major classes of anticoagulants are warfarin, prostaglandin-induced platelets inhibition, and adenosine diphosphate antagonist platelet inhibition. Prescribed. In the past, the recommendation to discontinue warfarin 3 days prior to treatment had been suggested. Multiple studies have shown that most patients who are within their therapeutic range, measured by the international normalized ratio 2 to 3 for most conditions and 2.5 to 3.5 for mechanical heart valves, can have most dentoalveolar procedures with local hemostatic measures without changing the anticoagulant therapy regime. This can consist of biting on gauze, sutures, oxidized cellulose, topical thrombin, and tranexamic acid as a mouthwash or on gauze. Cyclooxygenase inhibitors. The two types of medications that are commonly used in the geriatric patients are aspirin, which causes a permanent COX inhibition in the platelets, and the family of medications called non-steroidal anti-inflammatories, which cause a reversible inhibition of platelet aggregation that resolves 24 hours after discontinuation. In general, they are utilized for their anti-inflammatory and analgesic properties. Patients with atherosclerosis, it can be used in the management of acute myocardial infarction, arterial thromboembolism prophylaxis, myocardial infarction prophylaxis, percutaneous coronary intervention, stroke prophylaxis, thrombosis prophylaxis, transient ischemic attack, and unstable angina. It is also used like the non-steroidal anti-inflammatory drugs for its anti-inflammatory and analgesic properties. Discontinuing aspirin patients who are taking it for its prophylactic analgesic or anti-inflammatory properties is acceptable prior to surgery, but is usually not necessary. Generally, since it is a permanent inhibitor of platelet aggregation and the platelets have a lifespan of approximately 10 days, if it is discontinued 5 days prior to the surgery, no hemorrhagic increase would generally be noticed. If the patient is taking it for the management of a severe thromboembolic disease, discontinuation is not recommended. Use of hemostatic techniques like biting on gauze sutures, oxidized cellulose, topical thrombin, and tranexamic acid as a mouthwash or on gauze is suggested. Adenosine diphosphate antagonist inhibitors are a class of anticoagulants that are used in the management of acute myocardial infarction, arterial thromboembolism prophylaxis, myocardial infarction prophylaxis, peripheral component interconnect, stroke prophylaxis, thrombosis prophylaxis, transient ischemic attack, and unstable angina. Due to the morbidity of the disease that are managed with these medications, it is not recommended that they be halted for most dentoalveolar procedures. Bisphosphonate therapy. The therapeutic use of a group of drugs known as bisphosphonates has been associated with a destructive outcome termed osteonecrosis of the jaws, also osteonecrosis of the mandible, osteonecrosis of the maxilla. The majority of reported cases of medication-related osteonecrosis are associated with higher potency intravenous forms that are administered adjunctively for the chemotherapy. These case series and case reports have attempted to describe this phenomenon, which has mostly been observed in patients taking intravenous bisphosphonates for the treatment of certain types of cancer, multiple myeloma, breast cancer, and other cancers with osseous metastases, and bone disorders such as Paget disease of bone. Treatment with oral Fosamax, which is also a bisphosphonate, has resulted in a few documented cases of osteonecrosis of the jaws. Most cases of osteonecrosis were observed after tooth extraction patients taking bisphosphonates, though some cases were apparently spontaneous as there was no precipitating dentoalveolar surgery or trauma. It is important to avoid dental extractions wherever possible in patients taking bisphosphonates. If possible, patients should be rendered dentally fit prior to commencement of bisphosphonate therapy. Mucosal fragility and impaired healing. Common factors that impair healing in older patients include a decrease in the rate of cell proliferation, non-tensile strength, collagen deposition, and wound contraction. The aging process causes a change in the dermis and the mucosa that consists of a decreased glycoaminoglycans with escalated amounts of hydrophobic ground substance, decreased fibronectin synthesis and type 1 binding of collagen, and decreased immune competence, specifically T cell mediated immunity and antibody mediated functions. Clinically, this causes an increase in tissue fragility. Other coexisting factors that contribute to delay healing are poor nutrition, dehydration, decreased vascular perfusion, and the use of multiple medications. The disease process in elderly patients is difficult, but generally extractions are considered a relatively safe procedure. Patients with bleeding disorders must have preoperative evaluations prior to surgery. Other anatomical considerations to take into account are bone density, bone resorption patterns, and change in the blood supply to the mandible. In many elderly patients, the intermaxillary distance will be increased due to alveolar bone loss. In such cases, the simplest and most effective treatment may be to avoid surgery in the posterior region and use a removable prosthesis for oral rehabilitation. If a fixed prosthesis is used, the crown length will be long and generally not acceptable aesthetically to contemporary patients. If dental implants are being considered, there needs to be adequate bone volume. In elderly patients, there is an increased likelihood of osteoporosis, and when dental extractions were carried out several years previously, the alveolar bone will have resolved to leave an atrophic alveolar ridge. The soft tissue quality may also be inferior intraorally with a lack of keratinized gingival. This can lead to a less than optimal result. Anatomical considerations are paramount for safe surgical practice. Structures to be considered include the inferior alveolar nerve and vessels, the mental nerve, the maxillary sinus, and the floor of nose. These structures may come to lie more superficially as the alveolar bone reabsorbed. In many cases, plain radiography is adequate to make these assessments, but increasingly, CT scans are used to provide more accurate visualization of important structures. Three-dimensional CT scan reconstructions not only provide clearer picture of the position of anatomical structures, they also facilitate the construction of accurate surgical stents. Diminished compared to younger patients. This occurs as a result of the fact that the blood supply is much less derived from the inferior dental artery with increasing age. As a result, it is important that bone is attached to viable periosteum, as loss of bone vitality is more likely to occur otherwise. Planning for dental alveolar surgery. It is clearly critical that the patient and the clinician communicate effectively. Surgical goals must be set, and the patients must have a realistic expectation on what their outcomes are. This is good practice in most cases, but even more so with geriatric patients. A team approach is indicated, which will include the surgeons, the restorative dentist, and the frail elderly patients, the primary physicians or cardiologists. Preprosthetic surgery. It is important that the future needs for the replacement of teeth is remembered prior to the extractions. If this is not done, the excessive loss of bone during a minor oral surgical procedure may necessitate future ridge augmentation, which could have been avoided. When making these considerations, the two most important factors to consider are future form, aesthetics, and function. Clearly, it is important to be conservative in surgery to smooth sharp ridges to maintain the maximum amount of bone. In some cases, the use of some lining in the prosthesis will obviate the need for surgery in these cases. A relatively simple procedure can remove undercuts on the alveolar ridge, but it is important that these soft tissues are replaced accurately and are well supported to avoid loss of sulcus depth postoperatively. The act of raising the flap itself will induce a degree of resorption, and this should be done as traumatically as possible. Dental extractions. Attrition and brittleness of teeth, but particularly if root-filled, may complicate exodontia. Endodontic treatment itself may be complicated due to the deposition of secondary dentine. Other factors complicating surgical procedures include brittle dentine, low bone density, and hypercementosis. Many elderly patients have frail atrophic mucosa and a dry mouth, which complicates soft tissue healing. The extraction of multiple teeth is by no means confined to the geriatric patients. It is still true, however, that proportionately more elderly patients will require multiple extractions to facilitate oral rehabilitation compared to younger patients. It is important that liaisons carried out between surgeon and restorative dental surgeons so that the appropriate teeth are removed. The possibility of overdentures should be borne in mind, and therefore teeth which may be coronally unrestorable may still be of some use. In the longer term perspective, some prosthodontists prefer to start with a partial replacement prosthesis in order to facilitate the adaptation process, which may be prolonged in elderly patients. Concomitant medical conditions should also be considered. If necessary, the procedures should be staged over more than one appointment. When dental extractions are carried out, they should be done in a manner which recognizes the need for future dental unit replacement. If a salivary approach becomes unavoidable, any bone removal should be kept to a minimum. Endodontically treated teeth tend to be brittle and sometimes require a transalveolar approach to facilitate their removal. With improvements in endodontic techniques and instrumentation, it is frequently possible to save non-vital teeth. Although apical surgery is still carried out, current thinking is that well-executed ortho-grade root fillings are the treatment of choice. Apical surgery is often still required when associated periapical pathology is significant, for example, of radiolucency exceeding 1 cm in diameter. Age with implant failure. After adjusting for confounding coexisting medical conditions, failing implants related to patient's age happens rarely and is not a contraindication for placement. A success rate of 90 to 96% was found in the geriatric patients, equivalent to the corresponding population at large. A successful dental implant is defined as a direct functional and structural connection between ordered living bone and the surface of a load-carrying implant and is termed osseointegration. Primary stability, also called initial stability, is the degree of tightness on an implant after placement. This can be difficult in the elderly patient due to the coexistence of osteoporosis. Patients with the osteoporosis may exhibit longer healing times and therefore consideration needs to be given to this with respect to implant loading. Necrotic bone, irradiated bone, diabetes, or any pre-existing soft tissue pathology. The soft tissues in an elderly patient's mouth may be frail and atrophic, which can lead to impaired healing compared to younger counterparts. Relevant local factors include the quality of oral hygiene, the presence of active periodontal disease and dental caries. Active soft tissue disease such as vesiculobullous disorders or erosive lichen planus is also a contraindication. Smoking and along with its severe systemic effects also adversely affects the implant success rate. Patients should be encouraged to stop a minimum of 10 weeks prior to implant placement. If the patients do not discontinue smoking, they should be made fully aware of the detrimental effects of smoking and the decrease in the implant success rate as a part of the informed consent. Mucosal intolerance, difficulties with nerve compression, a strong gag reflex, poor muscular coordination, psychosocial reasons. These are examples of cases treated using dental implants and implant-borne prostheses. Implants in the partially dentate. The partial dentate patients also requires thorough evaluation to ensure that there is sufficient bone in all dimensions, width and height for correct implant placement. If there is insufficient bone, augmentation needs to be planned either as a separate procedure prior to implant placement or augmentation of the ridge at the time of implant placement or prior to implant placement of the dentition involves the preservation of the soft tissue profile by temporary support. This could include using socket-fitted dentures, placement of appropriately contoured bridge pontics, placing immediate implants, or even returning tooth roots so long as they do not have any associated pathology. The hard tissue profile may also be maintained by retaining roots without associated pathology and the immediate placement of the dental implants. Relatively simple measures such as avoiding zealous socket compression post extraction and the use of osteoplastic flaps can all contribute to maintaining bone as much as possible. Bone grafting. The optimal material for grafting is autogenous bone, which has both osteoconductive and osteoinductive qualities. Autogenous bone does have the disadvantage, however, of creating a donor site with the associated morbidity. Donor sites include the symphysis of the mandible, the ramus of the mandible, or a distant site such as the iliac crest. In the elderly patient, the same problems may arise with regard to vascularity, quantity, and the quality of bone. In addition, the temporary restriction in mobility which can be produced by iliac crest bone grafts may be particularly problematic in the elderly. It's important that once the graft has taken, that it is stimulated to prevent resorption by placing dental implants. This is usually carried out between 3 and 6 months after grafting. The grafts are usually fixed to the alveolus using screws and may be supplemented with a particular bone substitute. Several bone grafts substitutes have been developed. They can be divided into osteoconductive and osteoinductive types. Osteoconductive implies bone apposition onto and into a material from existing bone progenitor or bone cells. Osteoinduction implies the conversion of undifferentiated cells into osteoblasts or chondroblasts. The technique of guided bone regeneration uses a membrane which acts as a barrier, preventing the ingrowth of soft tissue, thereby facilitating the formation of new bone and bony defects. Membranes may be resorbable or non-resorbable. The disadvantages of the latter is that a further procedure is required to remove them when the bone has stabilized, as a result of the fact that non-resorbable membranes remain in the wound and thus act as a nidus of infection. Months to facilitate bone regeneration and maturation. The latter is particularly important as early removal leads to less mature bone being present, which is more prone to resorption. Frenectomy. Prominent frenal attachment can prevent the prosthesis sitting correctly. In some cases, frenectomy may be required. With increasing ridge resorption, the frenal attachments become relatively more prominent with increasing age. In many cases, such surgery can be avoided by generously relieving the prosthesis in the relevant area. Many techniques of frenectomy are described, but the use of carbon dioxide laser can be beneficial to minimize soft tissue shrinkage. Maxillary tuberosity reduction. The carbon dioxide laser can also be useful in this situation. One technique described is the use of a double ellipse technique. In this technique, an ellipse of mucosa is removed on the surface mucosa on the ridge crest to remove excess tissue together with an underlying ellipse of deeper tissue to allow the tension-free closure. Atrophic mandible and denture mental nerve compression. As the alveolar bone resorbs, the inferior dental nerve, particularly as it emerges from the mental foramen as the mental nerve comes to lie more superficially. It can come to lie so superficially that in the mental region it is not covered by bone at all. Clearly, a prosthesis lying on such a nerve can cause significant pain and discomfort. The principal methods of dealing with this include relief of the denture in the relevant area, soft lining of the denture and the use of implants to bear the denture and nerve repositioning. This latter procedure is rarely carried out and runs the risk of postoperatively sensibility disturbance. Vestibuloplasty. Various vestibuloplasty techniques have been described with the intention of effectively increasing the height of alveolar ridge available for prosthesis placement. This technique will only be successful if there is sufficient underlying bone, and therefore augmentation of the alveolus may be necessary. The alveolus left without soft tissue support post vestibuloplasty can either be left to granulate or covered with a split thickness mucosal or skin graft. These techniques have met with varying degrees of success and also introduced the problems of a second surgical site from where the graft is derived. One alternative to grafting is laser vestibuloplasty and submucous vestibuloplasty. Both of these techniques are not in common use today. Denture-induced hyperplasia. Denture-induced hyperplasia is precipitated by long-term ill-fitting dentures, stimulating soft tissue overgrowth. Excess tissue can be removed using a scalpel, but the superior healing properties of the carbon dioxide laser make this a useful mode of excision. It is important to try and minimize the amount of surgical reduction required whenever possible, and this is facilitated by the use of tissue conditioner or other prosthesis modification. In some cases, if acceptable to the patient, leaving the prosthesis out altogether for a short period can be very useful. Biopsies. Biopsy is the process of providing a tissue sample that can be subjected to histopathological examination. It is important that the possibility of malignancy is borne in mind with all patients, but particularly so with the elderly. The incidence of malignancy increases with age. Unless a lesion is clearly clinically benign, it is safest to carry out an incisional biopsy to determine the nature of lesion. Excisional biopsy should only be carried out for clinically benign lesions. Local analgesia will facilitate biopsy, but considerations may not to be given to general anesthesia if the lesion is in accessible part is in an inaccessible part of the oral cavity. It's important that local anesthetic solution is not infiltrated directly into the tissue to be removed, as tissue distortion may be produced. Basic biopsy techniques. The principles of good biopsy technique. Biopsy the most suspicious looking area, incisional biopsy. Do not inject local anesthetic solution into the future specimen. The specimen should be of adequate size. If the lesion is large, more than one incisional biopsy may be required. Remember that the clinical appearance does not always correlate with the microscopic. It's important that the specimen does not taper to a point on the deep surface. If an incisional biopsy is carried out and the histopathological report appears incongruous with the clinical appearance, consideration should be given to repeat biopsy for obtaining cells from a lump, which are then subjected to cytological examination. It is particularly useful in the aspiration of lymph nodes and major salivary gland lesions. So the key points of this lecture is geriatric patients generally have comorbidities, and because of this, the provider must be aware of the necessary modification of treatment. Polypharmacy is common in the elderly, so drug interaction and potential hazards should be recognized and accounted for. Because of polypharmacy, hyposalivation can be present in the elderly, which can increase caries rate, and because of fragility. Although it is safe to operate on the elderly, appropriate consultations should be obtained prior to surgery. Thank you.